I want to welcome everyone today to this series that we've been doing on trauma-informed care. Today, we're going to tackle PTSD, and we're very, very fortunate to have two clinicians from the New Orleans VA here in New Orleans, Louisiana, who are going to be doing PTSD for us. We have Dr. Chelsea Ennis and Dr. Michael McCormick. Docs, welcome. Thank you so much for your time and your presentation as you take us on this journey through post-traumatic stress. I turn it over to you. Thank you.
All right, thank you very much. I am Mike McCormick. I'm happy to be talking about PTSD with my colleague, Dr. Ennis, who is our PTSD team lead here at the VA. We collaborate on cases together. We have no conflict of interest. We have no commercial interest to report. And just go ahead and read this. The contents of this report do not represent the views of the Department of the VA or the United States government, just a standard disclaimer there. But Dr. Ennis and I did collaborate and put these slides together, mostly related to the content on the National Center for PTSD. So we're going to talk about today prevalence and symptoms of PTSD, comorbidity, what often goes along with PTSD, and then we're going to touch on some of the treatments currently offered, best treatments for PTSD. And I'll touch on a few treatments that have not yet been approved for PTSD, because there's usually a lot of questions about that. So starting with the PTSD prevalence, approximately 90% of individuals in the community are exposed to traumatic events. And what we often emphasize is that just because you're exposed to traumatic events does not mean you will get PTSD. We say that a lot. Typically only about 8.7% of these individuals will develop PTSD over their lifetime. And so, what's understood is that a lot of people experience trauma. Few people, relatively speaking, develop PTSD. And it's thrown around a lot, the term I have PTSD, but it is a true syndrome, a true condition with criteria. Rates of PTSD are higher among veterans and those people in professions that are exposed to trauma, like you would expect: police, firefighters, emergency personnel. And, women in general, female population experience PTSD for a longer duration than men do. They have higher rates of PTSD, thought to be due to, again, higher incidence of traumatic events, whether it's sexual trauma, rape, military combat, etc. Or interpersonal violence is the other part. All right, and so getting into the PTSD key features, I'm going to turn that over to Dr. Ennis.
All right, thank you. So I'm going to be talking about the diagnostic criteria for PTSD and how we diagnose PTSD, because I think a lot of times, in movies and all sorts of places, we hear PTSD or post-traumatic stress disorder, and there's actually a lot of kind of myths about what PTSD is, what it looks like, and there's a lot of different symptoms of post-traumatic stress disorder. So we're going to spend the first part of the presentation just talking about what does this disorder look like, what are the symptoms, and how do we diagnose it. So what I have on here is the DSM, or the Diagnostic and Statistical Manual of Mental Disorders, that has our handbook of hundreds of different mental health diagnoses. One of those is post-traumatic stress disorder, and there is more than 20 symptoms of post-traumatic stress disorder that we're going to go through today. So the essential feature, and if you can jump to that next slide for me. Thank you. The essential feature of post-traumatic stress disorder is the development of characteristic symptoms following exposure to one or more traumatic events. This is what we call criterion A events or criterion A stressors, which is essentially going through a trauma. Now, criterion A stressors are events in which an individual is exposed to actual or threatened death, serious injury, or sexual violence. And these stressors include things like what we classically think of with military veterans, which is combat. It includes sexual assault, childhood abuse, serious accidents like a very serious car wreck, natural disasters, things like earthquakes or hurricanes, and terrorist attacks. There are several ways in which an individual might experience a traumatic event. First and foremost might include experiencing it directly. So a veteran that is deployed to Iraq or Afghanistan going through combat. Another way might be witnessing something happening to someone else, and maybe seeing someone else injured or killed or sexually assaulted. Then we also have another category of exposure, which is learning about it. So this might be learning about one of these criterion A stressors that happens to a close family member or a close friend. So learning that a family member or friend has been assaulted, for example. And then kind of the last category of traumatic exposure we have is repeated or extreme exposure to details. So this would be kind of repeated or extreme exposure to very sensitive details. So this might be, police investigators who are routinely exposed to photographic evidence of maybe murder scenes or other kind of crime scenes. And I do think it's important to note that exposure to electronic media, for example, seeing something on the news does not qualify rather as a criterion A stressor. So there's lots of different ways that a person might be exposed to trauma. Now, a lot of time we also hear about, trauma in other ways, like, very stressful things that happen at work, or, maybe being around a colleague who is verbally harassing someone, right? And while these types of experiences are also very distressing and upsetting, they're not what we would call a criterion A stressor. And again, when we talk about criterion A's with PTSD, we're talking about threatened death, serious injury, or sexual violence. Okay, next slide, please. So there's essentially 4 sets of symptoms, our B, C, D, and E symptoms. And I'm going to walk through these and give some various examples of these symptoms so folks can kind of understand a little bit more when we talk about. The first set of symptoms that we're going to be talking about with PTSD is what we call intrusion or re-experiencing symptoms. And these symptoms are exactly what they sound like. They're ways in which symptoms of trauma are intruding into an individual's everyday of life, or they're ways in which an individual is kind of constantly re-experiencing their traumatic stressor. The first symptom being recurrent, involuntary, and intrusive distressing memories. So folks with post-traumatic stress, military veterans are going to report things like memories or images of their trauma popping into their head several times in the past month in ways that is upsetting or distressing. So not merely just thinking back to the traumatic memory, but it's coming in to their kind of conscious and really bothersome and upsetting. The second symptom of our B or our intrusion symptoms are recurrent and distressing dreams. So what this tends to look like is nightmares about the trauma, which tends to look like either replaying the trauma. Almost patients will report feeling like they're kind of living through the trauma again in their dreams, or the dreams might be thematically related. So there might be some aspects of the trauma that's in their dreams. And the impact of this is that oftentimes individuals are going to wake up, they're going to be unable to return back to sleep and lose a lot of sleep from these trauma-related dreams. The third intrusion-based symptoms we have is dissociative reactions. Now, dissociative reactions are a little bit less common, but it's kind of colloquial, what we hear all the time, patients saying they might have flashbacks. Now, flashbacks or dissociative reactions are ways in which the patient feels as if they're actually back at the time of the event. So this might be, for example, a military veteran who's been to combat actually feeling like maybe they're back in Iraq again, actually feeling like they're reliving the event. And it's hard for people in these instances to know that they're actually safe and then that they're not living the trauma again. So as you can imagine, something like flashbacks is going to be very upsetting and very distressing, and oftentimes noticeable to the folks around the patient that's experiencing it. Our fourth intrusion-based symptom is what we call intense and prolonged psychological distress to reminders of the trauma. So trauma triggers. Folks who have been through trauma are often going to have specific things in their environment or around them that upset them because they remind them of the trauma. So for our combat veterans, that might be certain smells or sounds, maybe the sound of helicopters or the smell of diesel fuel. For folks who have lived through sexual assault, it might be individuals that maybe look like the perpetrator or certain songs that were playing around at the time of the sexual assault. And when these type of reminders come up in an individual's day-to-day environment, they're going to be, as you can imagine, very upsetting, catch folks very off guard, and oftentimes throw their whole day off. And finally, the last symptom there is these physiological reactions. So in response to these trauma triggers, whether it be, the smell of diesel fuel or the helicopter sounds, folks are oftentimes also going to have a bodily or more physiological response. These are going to be things like heart racing, sweating, having trouble breathing, feeling dizzy or nauseous, anything that goes along with kind of this panic attack like response of confronting some of these triggers. So in order for someone to get diagnosed with PTSD, they have to have at least one symptom from this category. Next slide, please. The next category of symptoms is what we call avoidance-based symptoms. And similarly, a patient has to have at least one of these two symptoms to be diagnosed with post-traumatic stress disorder. So the first symptom is avoidance of the memory itself. As you can imagine, someone that goes through a very distressing traumatic event isn't going to want to think about it, isn't going to want to talk about it. And so what routinely folks do to kind of avoid thinking about their trauma is to oftentimes stay distracted. So we'll hear a lot of times from patients, working a lot to avoid thinking about the event, or trying to always play on their phone or listen to music, or spend time with family or friends, or even use alcohol or other substances to avoid thinking about these traumatic memories or emotions. Another symptom here might be specifically avoiding people, places, or situations, or even conversations about the trauma. So it's very common that folks might avoid, going to certain situations that might remind them of the trauma. So for our combat veterans, that might be driving in certain areas of a town that remind them of deployments, or listening to songs that played during deployments. It might be for a woman who's survived sexual assault, maybe being around men or being around people that remind them of their perpetrator. And all of these symptoms are very normal and characteristic in the development of post-traumatic stress disorder. And we're going to talk about a little later on how we manage some of these symptoms. Okay, next slide. So our third category of post-traumatic stress symptoms are what we call negative alterations in cognitions and mood. And if we're to distill this down, what we're really talking about is negative or low mood and kind of negative thoughts that tend to run through people's mind. So the first symptom here is an inability to remember important aspects of a trauma. What we're talking about here is what we call traumatic forgetting. So an individual who's gone through trauma might be so traumatized or have been so upset during the trauma that they actually don't remember pieces of the event. So for example, they don't remember how they got out of the situation or what actually happened during parts of the trauma. Now, this is not normal forgetting. So, if we're working with a Vietnam era veteran who maybe it's been, 40, 50 years since their trauma, if they don't remember small pieces, that's not what we call traumatic forgetting. Traumatic forgetting is not remembering big, important parts of an event. And this is not due to losing consciousness during the trauma, like having a traumatic brain injury. And it's also not due to alcohol or substance use that might have been present during the trauma. The second symptom here is negative beliefs about oneself, others, or the world. So oftentimes when people go through trauma, they develop a negative belief system about their self, like I'm worthless or I'm broken. They have kind of negative thoughts about other people, like the world can't be trusted, and even negative thoughts about the world, like the world is dangerous or no place is safe. Another symptom that goes along with that in terms of negative thought patterns is kind of what we call self-blame, or a lot of times we hear a patient having survivor's guilt, especially for combat-related situations. So these are thoughts like a patient maybe could have done something differently to prevent the event, or maybe feeling like the event is their fault, or that they should have died instead of someone else. And those thoughts are some really, really heavy thoughts to be carrying around after our trauma. Kind of following that, our fourth symptom is just persistent negative emotional states. So folks who have gone through trauma might report generally feeling fearful or in horror a lot of the time, feeling really shameful, feeling angry a lot of the time, and just generally feeling like these big negative emotions are persistent and they're not going away. A fifth symptom in this category is what we call kind of diminished interest or anhedonia. So this is just generally a lack of interest or pleasure in things that maybe a patient used to enjoy before their trauma. So maybe they're not enjoying, hanging out with their family anymore. Maybe they're not enjoying hobbies like fishing or hiking or working out, and just generally not having interest in things that they used to. The sixth symptom here is feeling detached or estranged from others. So it's really often the case that a lot of folks that go through trauma after trauma are really going to feel like they don't relate to others maybe in a way that they once did, or they can't open up to other people anymore. And of course, this is going to be a really kind of upsetting and uncomfortable feeling, to feel like you're not relating to people in a way that you once did. And then finally, the seventh symptom here is overall just a difficulty experiencing positive emotions, things like love and happiness. So a lot of our patients will report things like, going to a wedding or maybe seeing their child be born. These are situations where ideally you should feel happy about them or feel some sort of positive emotion. And a lot of folks with PTSD are going to struggle to experience kind of basic positive emotions in situations that should invoke them. Okay, next slide, please. Now we have our last category of traumatic stress symptoms, which is alterations in arousal and reactivity. And so the first symptom here is irritable behavior or angry outbursts. So a lot of the patients we're working with are going to report kind of that their temper goes from 0 to 100, and that this was not the case maybe before they had a traumatic experience. And it's going to manifest behaviorally. So that might be yelling or raising your voice. It might be throwing or, hitting things or punching walls, or behaviorally displaying kind of their anger. And again, this is something that would have to have changed. So folks generally wouldn't have these behaviors before a trauma, and these symptoms would develop in the wake of a trauma. The second one might be things like reckless or self-destructive behavior. So ways in which a patient is maybe engaging in things that might hurt them. So this might be, speeding. This might be substance use that's risky. I've even worked with folks who were, for example, linemen and took more risky jobs at work that might increase their risk of dying on a job site. So it can be manifested in a lot of different ways. Then we have hypervigilance. Hypervigilance is essentially keeping your head on a swivel, always feeling like danger is nearby, and doing a lot of things behaviorally to protect yourself from danger. So this might be avoiding crowded places, or if you're going to go to somewhere like Walmart or grocery store, only going at really late or really early in the morning where there's not a lot of people around. It might be placing yourself in a restaurant so that you've got your eyes on the door. There's also a lot of hypervigilant symptoms that can manifest in the home. So a veteran might be maybe doing perimeter checks around their house, or checking their alarm system multiple times, or even checking their locks multiple times a day. The next symptom is exaggerated startle response. So folks who go through trauma are often very jumpy. So if they hear a sound or someone kind of walks up behind them, not only are they going to be easily startled, but it's going to take a long time for these folks to recover. So most of us, if we are startled by a loud noise, up to a half a minute or so, we're feeling back to normal again. For folks with post-traumatic stress, this is going to throw their whole day off. It's going to be really upsetting and kind of linger there. Finally, the last two symptoms are problems with concentration and sleep problems. So with concentration, oftentimes our veterans are going to be reporting that they can't keep their mind on track. Maybe they're reading the same thing over and over again. That's difficult even to pay attention in everyday conversations. And obviously, these are symptoms we might see with someone with a traumatic brain injury, but we're also seeing these symptoms among patients that don't have any kind of traumatic brain injury associated with their trauma. And finally, sleep disturbances. This is going to be difficulties falling asleep, so it might take hours to fall asleep. And then once a patient is asleep, waking up multiple times during the night, Oftentimes folks with post-traumatic stress are only getting, 2 to 4 hours of sleep a night, and that's going to be very, very distressing. And in this category, in order to have a diagnosis of PTSD, a veteran has to have 2 or more symptoms. Okay, next slide. Finally, as with all of our mental health diagnosis in the DSM, there's a couple other symptoms that have to be present. One is that these symptoms have to be present for at least 1 month. So if a patient experienced a trauma 3 weeks ago and was experiencing a lot of different trauma-related symptoms, at that time we would say their symptoms are kind of normative. Like Dr. McCormick mentioned earlier, most folks who go through trauma experience some traumatic stress in the days and the weeks following their trauma that tend to go away on their own. If it's been more than a month after the trauma and the symptoms still persist, that's when we call it post-traumatic stress disorder. Additionally, we'd want to ensure that a patient has significant distress and impairment from their symptoms. So in terms of distress, the patients are really bothered by their symptoms. They don't want to have them, and it's bothersome on a day-to-day. And impairment, oftentimes we're going to see difficulties in, romantic and family relationships, difficulties in their occupation or at work due to their symptoms, difficulties, in the household. There's going to be a big impact of these symptoms. And finally, there's a lot of symptoms of post-traumatic stress disorder that are often characteristic of other symptoms. So for example, I mentioned the symptom of kind of having loss of interest or pleasure. That's also a symptom of depression. So we always want to ensure when we're talking about PTSD symptoms that multiple of these symptoms are present and that it's not actually a different mental health diagnosis. Okay, I'm going to pass it back to Dr. McCormick. Or am I doing this one? No, I'm on the slide. Sorry.
Yeah, you can keep going. I think.
Okay. Yep, and I'm next with the next ones. Okay, so in terms of comorbid conditions, individuals with post-traumatic stress disorder are 80% more likely than those without PTSD to have symptoms that meet diagnostic criteria for at least one other mental disorder. What we're saying with this is if someone has PTSD, it's also pretty likely that they're going to have another mental health diagnosis because these symptoms, mental health diagnoses tend to walk hand in hand with each other. There's a whole host of comorbid conditions that go along with post-traumatic stress disorder, things like depression, bipolar disorder, anxiety, and substance use disorders. Substance use disorders are especially common among our service members, especially among male veterans. And traumatic brain injury is another comorbid kind of medical condition. And among U.S. military personnel and combat veterans who have been deployed post 9/11 to places like Iraq and Afghanistan, the co-occurrence between PTSD and traumatic brain injury is around 48%. So we're seeing really, really high rates of TBI among this era cohort. Okay, next slide. All right, so now we're going to be walking right into treatments for post-traumatic stress disorder. It used to be back in the day that when someone was diagnosed with PTSD, it was a lifetime sentence. Once you're diagnosed with PTSD, you've got it for the rest of your lifetime. And the good news is that this is no longer the case. We have very, very effective treatments that work really, really well. There are helpful treatments that include both psychotherapy and medications. And so where I want to start off with, next slide, is to talk a little bit about efficacy rates. And so all of this data comes from the National Center for PTSD, which is the Department of Veterans Affairs website. So the VA has what we call clinical practice guidelines. And clinical practice guidelines are essentially a big council of subject matter experts in treating PTSD, both on the biological and kind of psychological end, that come together to evaluate the literature in terms of what treatments tend to work best for PTSD. And overall, the clinical practice guidelines recommend that treating PTSD using individual trauma-focused therapy, specifically things like PE, CPT, or EMDR, over medications. And as you can see here, these are kind of the efficacy rates. For out of every 100 veterans that do a trauma-focused psychotherapy, At the end of treatment, 53 of those veterans will no longer meet criteria for post-traumatic stress disorder. And so that shows kind of, again, psychotherapy is the best treatment that we have at this time. Kind of looking at medications, every 42 out of 100 patients who do medications that Dr. McCormick is going to talk about no longer have PTSD once the medications are working. And then if you look at no treatment, it's very unlikely that folks are going to kind of have symptom remission or no longer meet criteria if they're not going to have any treatment at all. Okay, so where I'm going to start is with our trauma-focused psychotherapies. And I'm going to talk about 3 different trauma-focused psychotherapies. Across VAs, there's differences in variability and in access to these treatments. But these first 2 treatments that I'm going to talk about, you're going to see there's a gold star on the slides, and that indicates that these are our best, most effective treatments. And there's 2 of these best, kind of what we call first line or gold standard treatments, both of which you can be found locally at this VA. And at most VAs, one of these treatments can be found. So the first one is called prolonged exposure therapy. Prolonged exposure therapy is an 8 to 15 week treatment in which a patient would come in once a week for these weekly sessions for around 3 months or so. Post-traumatic stress or prolonged exposure targets the primary symptom of PTSD, which is avoidance. So earlier I mentioned that folks with PTSD try to avoid their memories. So they might always be pushing traumatic memories or images or feelings out of their mind, telling themselves, don't think about it. Don't think about that memory. Whatever you do, don't think about that memory. The other way that people tend to avoid with PTSD is tend to avoid certain people, places, or situations. Again, they might be avoiding crowded places or, certain smells or certain sounds. And while avoidance works really, really well in the short term for patients, right? If they avoid going to that crowded grocery store, they immediately feel better. The problem over time with avoidance is that it maintains or it keeps post-traumatic symptoms around. So we know that folks that use avoidance as their primary coping strategy to manage PTSD are less likely to recover and are more likely to develop PTSD in the first place. So we know avoidance is not a helpful coping technique. Prolonged exposure is all about not avoiding anymore. And so we have kind of 2 techniques as part of prolonged exposure to kind of push back or target this avoidance. And one is imaginal exposure. So I mentioned folks are always trying to push the memory out of their mind, tell themselves not to think about their trauma. If I were to tell you both right now, don't think about a pink elephant. Whatever you do, don't think about a pink elephant. What happens immediately? You're actually thinking about a pink elephant. The same thing works for trauma. The more folks try and tell themselves don't think about their trauma, the more they're actually thinking about it in these memories, in these nightmares they don't want to have. And so the first thing we're going to do as part of prolonged exposure is have someone revisit their trauma, which sounds really scary. This entails going back through your trauma memory out loud and also listening to it for homework. And while it can be distressing at the beginning of treatment, what happens over the course of these weeks of treatment is it becomes less and less and less distressing. Now, what we can't do is take away the memory or get rid of the memory, but what we can do by doing these imaginal exposures is make the memories less distressing for the patient so that when the memory pops into their mind, they're no longer having a big distress response or a big anxiety response to it. The other piece of prolonged exposure is going to be what we call in vivo exposure, which is having an individual slowly approach safe situations that they've been avoiding. So we're going to make a big list of all the situations that an individual has been avoiding, whether it be the grocery store or the smell of diesel fuel or maybe helicopter sounds or maybe watching a war movie. We're going to make a list of all these situations and have the patient or the veteran gradually start approaching these situations to learn that these situations aren't dangerous, that their anxiety will go down over time, and that they are in control, that they can manage these. The biggest risks with a treatment like this are obviously discomfort in talking about, your trauma history, as well as approaching a lot of situations that you've been avoiding for a long time. But we know these treatments are extremely effective. And the distress only lasts for a little bit of time. Within several weeks, this distress goes down and we start seeing a lot of symptom reduction. Now, the other piece of this treatment prolonged exposure is homework, right? While it would be great if a patient could show up and I could magic wand away their symptoms for 50 minutes once a week, we know the reality of treatment is that the folks that are going to get better quickest and have the biggest symptom reduction are folks that are putting in a lot of practice outside of session. So what that's going to look like for prolonged exposure is going to be listening to session recordings of them talking about their trauma, as well as approaching these safe but avoided situations, right? So that might be learning how to go to the grocery store several times, or being comfortable with hearing helicopter sounds. So we might send folks to do these things that they've been avoiding. And like I said, prolonged exposure is very well researched. It has decades of research showing that it decreases symptoms, and it's effective for all trauma types, whether it's combat, sexual assault, natural disaster, it works for everything. All right, next slide, please. So I want to talk a little bit now about our second kind of gold standard treatment. You can see the gold star there. This treatment is called cognitive processing therapy, and a lot of research also supports this treatment. Similarly, for lots of different types of trauma, combat, sexual assault. This is a 12 session treatment, so generally around the same time frame of about 3 months, where a patient's going to be coming in once a week to complete the treatment. This treatment really targets negative thinking styles that have arisen as a result of trauma. So earlier we were talking a lot about how folks with post-traumatic stress have lots of negative thoughts, whether it's blame, like it's my fault or I should have done something differently, or feeling like they can't trust anyone or the world's dangerous, that they're broken. And a lot of these negative thinking styles keep people really stuck in their trauma. I like to have people, when they're thinking about this treatment, think about PTSD like a campfire. What we need to keep a campfire burning is fuel or logs in the fire. And every time patients are having these negative thoughts, like it's my fault, I should have done something differently, the world's not safe, they are putting logs in this campfire that is keeping the fuel of PTSD burning. So what do we do in this treatment? Essentially, we teach folks a series of skills to be able to challenge their negative thinking styles. So we will teach patients how to determine which thoughts that they're having have facts and evidence to support them. Now, a lot of times when I'm talking about this treatment with patients, they think what I'm telling them is to think positive thoughts, to think that nothing bad will ever happen again and everyone can be trusted. And that's not the goal of cognitive processing therapy. The goal of cognitive processing therapy is to have patients think realistic thoughts. And we do that by putting thoughts on trial and really looking at the evidence to support the thought, looking at evidence that maybe the thought is not as realistic. And if we find that some of these thoughts, like the world is completely dangerous or no one can be trusted, if we find that there's not a lot of evidence to support these thoughts, then we're going to work with patients to come up with new, more realistic, more rational thoughts that are based on evidence. So ideally, what we'd want a patient to do is kind of recognize that not everyone is dangerous, that not every place they go is dangerous, that there are some people in the world that can be trusted. And we do that by kind of learning to have them challenge their own thinking. Similarly, with prolonged exposure, the treatment we just talked about, risks of cognitive processing therapy are also discomfort about talking about the trauma, right? In order to talk about maybe whether it's someone's fault in the trauma or what things could have been done differently, we have to kind of walk back through the trauma and talk about all the logistics of actually what happened during the trauma, which can be uncomfortable for folks. Similarly to the last treatment, this treatment also has treatment. So this treatment also has homework. What homework tends to look like when we're talking about cognitive processing therapy is a lot of worksheets. We teach patients a series of skills to help them challenge and change their own thoughts. And this means daily worksheets, working at kind of identifying their negative thoughts, learning how to challenge them, and how to come up with new thoughts. Okay, next slide, please. The last psychotherapy that I wanted to talk a little bit about is a newer treatment. And you can see there's not a big gold star in the corner. And so I want to talk a little bit about what that means. Written exposure therapy is what we call a second line treatment. There's a lot of research showing that written exposure therapy actually works just as well as prolonged exposure and cognitive processing therapy, those two gold standard treatments. However, at this point in time, we still don't have enough research showing that this works just as well. I anticipate in the next several years this might change. However, at this point in time, it's what we call a second line treatment. There's a lot of reasons why someone might want to do this treatment. I'm going to talk about some of them. So written exposure therapy, which we offer here at the Southeast Louisiana VA, is a 5-session treatment. So compared to the other two treatments, prolonged exposure and cognitive processing therapy, it's a lot shorter. We can treat your symptoms in a lot briefer period of time. Written exposure therapy is essentially 5 weeks in which an individual come to session and process their trauma through writing. So during these sessions, 5 sessions, an individual will write for 30 minutes during every single session about their trauma. And very similarly to prolonged exposure, just the not avoiding thinking about or talking about the trauma, patients are going to do this through writing, where they're slowly going to approach and confront these trauma-related memories that they're going to be having through writing, and also briefly through processing with a therapist during session. Similarly to the last treatments, risks involve kind of discomfort and not wanting to think about, talk about, or write about the trauma. But another added benefit of written exposure therapy is that there's no homework to it. So this treatment, which is a lot shorter and doesn't have treatment, data suggests that, again, it works pretty well, if not just as well as some of these other treatments that I've talked about. So this is going to be a really beneficial treatment for a patient that maybe doesn't have 12 weeks to be in therapy, or is maybe really, really busy in life and is not going to have time to to be able to do homework outside of sessions. So like I said, while it's not a first-line treatment when compared to the other treatments, it's very effective in reducing symptoms. So that was my overview of generally trauma-focused treatments for psychotherapy that we offer here at this VA and that are commonly found in VA healthcare systems. They're very effective. They work. If people do these treatments, they're likely to have a significant reduction in symptoms and possibly not even meet criteria for PTSD at the end of them. So now I'm going to go ahead and pass the torch now over to Dr. McCormick to talk about some other treatment options.
All right, thank you. And full disclosure, before we get into the medication part, as Dr. Ennis mentioned, therapy is a superior treatment. It's really the best treatment that we have. And if you were to pick one treatment, it would be therapy. As research has fleshed out, like Dr. Ennis said earlier in the presentation. But medications are also a good option, which we'll get into. And sometimes you can have really good results when you combine both medication and therapy. So in terms of medications, there's 3 that are FDA approved for PTSD. And as you may or may not know, all medications have 2 names. There's a generic name and there's a brand name. And so in this particular case, sertraline, paroxetine, and venlafaxine are the generic names. And then in parentheses, you can see the brand names there: Zoloft, Paxil, and Effexor. And what it means, we'll get to this in another slide, but basically these medications have gone for the FDA approval. They've gone under special studies where it's aimed to show a benefit for PTSD. Some other medications are helpful, certainly, and your doctor may recommend other medications other than these 3. We certainly prescribe ones that are different than these 3, but these are the ones that have the FDA indication. And you might see SSRI or SNRI. That's just a fancy way of saying that one group of medication increases the amount of serotonin in the body, and I emphasize in the body and not just in the brain, because we'll get to maybe what kind of other effects that can have. And then SNRI is same thing, serotonin, but then we're adding norepinephrine, and serotonin and norepinephrine are neurotransmitters when we talk about them in the brain. All right. So yeah, other antidepressants, as I mentioned, can be effective. It's just that these 3 have undergone the rigorous studies to get FDA approval. And these are some other ones. Obviously, we don't need to go through all of them, but you can see 2 of the ones, Paxil and sertraline, are SSRIs, venlafaxine, and then there's a handful of other SNRIs that that are indicated. I put this slide up here because your doctor may mention some of these names. These are the most common ones that we see prescribed for PTSD. And so how do these medications work? Well, we think that, and we have pretty good evidence that the amount of neurotransmitters in the brain are decreased. So in other words, serotonin may be decreased, norepinephrine may be decreased in individuals with PTSD. And so when we have that, the three medications and the other ones that I discussed, they help to basically improve the levels of those neurotransmitters, serotonin and norepinephrine, thereby kind of getting a more normal balance of these neurotransmitters. And so they're helpful for treating not only PTSD, but as we talked about earlier, the comorbid conditions. If you think back to criterion D, which is essentially a lot of depressive symptoms, these medications can treat PTSD, but also depression and anxiety. And so you're getting a lot of bang for your buck if you can treat PTSD, depression. These medications are also first-line treatment for other anxiety disorders like generalized anxiety, OCD, specific phobias. All right, so that's about the medication. What do I do to get started? So basically, setting up an appointment with your provider, telling your provider exactly what your symptoms are, and then usually what's going to happen, I know a lot of veterans that I work with come in and they're a little bit concerned about just being told, what to take. And so oftentimes when we have a conversation about a medication, it's going to be in a fashion that is shared decision making. And so the patient, the veteran, will come in and tell them what their symptoms are, and they may say that I'm really concerned. A lot of times, we all do reading, we all check out Google, and they're concerned about certain things about medications. And that's perfectly fine to bring into conversation and say, look, I want something that does this, this, and this. These are my significant symptoms. And then the doctor may say, well, based on what you've told me, this medication would be best. And so that's shared decision making. And you usually come to a mutual decision about your treatment. You're oftentimes are not told, here, take this, see you in 3 months, and we'll see how you're doing. So it is usually a very relaxed environment talking about treatment options in terms of medication. Okay, so now you went to your doctor, you told him your symptoms, medication's recommended. What do? Well, you want to be consistent with taking your medication, usually at the same time every day. However, your doctor will probably give you a little bit of leeway. For instance, if the medication maybe makes you tired when you first start it, you might take it at bedtime. If it tends to keep you up at night, you'll probably take it in the morning. And it's important to note it can take a little while for the medication to start working. Could be 3 weeks, 4 weeks, 6 weeks. So a big thing is to not stop it too early, because a lot of times benefit comes down the road. And if you do have concerns where you want to stop it, of course, talk to your doctor and let him or her know what's on your mind. But the key takeaway from this slide is patience is important when starting a medication, to wait and see benefit. I can tell you a lot of times people will stop taking it after 2 or 3 weeks, and really we call that an inadequate trial, because there just simply wasn't enough time to see if the medication was helpful or not. All right, what are the risks? Big question. What am I looking at here? What am I getting and what am I giving up? A lot of times these are the most common side effects. They're usually mild to moderate, and we're talking about upset stomach. And so earlier when I mentioned that these medications increase serotonin in the body, they truly do. And serotonin is found in the GI tract. It's also found in the GU tract, which we'll get to. But upset stomach, therefore, when you're increasing serotonin in your intestinal tract, it's certainly expected that you might get upset stomach, maybe diarrhea in some cases, abdominal pain, reflux. Fatigue is another big one. I hear a lot, that the fatigue can be significant in the first week or 2 or maybe 3, but usually that subsides and you get your normal energy levels back after that first few week period. Sweating, headache, dizziness, those are all fairly common to start. Again, typically they go away. That's the important point. If they don't go away, then ultimately you have to decide whether the benefits of the medicine outweigh the risks. And that's the key point, is that what I'm getting from this medication in terms of symptom reduction, is it better than the side effects that I'm experiencing? And then, of course, the other thing, as I mentioned in the GU track, this is a thing people don't like to talk about, right? Decreased sexual drive, we call that libido, difficulty having an orgasm, but it's important for your doctor to know that. I can guarantee you any psychiatrist, nurse practitioner, nurse, even some nurses are prescribing medicines, pharmacists can prescribe. They've heard that a lot, and it should be mentioned. So yeah, most of them are short term. Others may last a while. It's just important to keep a lookout and communicate with your doctor. As I mentioned, could take 4 to 6 weeks for benefit. Keep taking it on a daily basis, and then good communication is key. The other thing I want to emphasize here is that you may not achieve the benefit you want on the first medication trial. And so oftentimes, we'll have veterans that may come in and it might be on their second medication or third medication that they really find the one that works for them with minimal side effects. And unfortunately, some people might give up after the first medication and say, oh, medication's not for me. I didn't like the way I felt on it. Well, it could be that you have, very different results on the second or third try. Hopefully you get it right on the first try. That'd be great. But it doesn't always work out that way. So we always emphasize, don't give up if after the first try, if you're still having symptoms, certainly it's worth a talk about what other options might be helpful. And I also wanted to mention nightmares. And so the slide on intrusion. Nightmares are very common in PTSD. Our best medication is prazosin, which is an alpha-1 blocker, and it helps we think to decrease the sympathetic surge in the middle of the night that results in nightmares. We can see really significant benefit with doses as low as 1, 2, 5 milligrams. Sometimes we need to get the dose up higher. But all in all, it's a weak blood pressure medicine that over time we found that's very helpful for nightmares. And the most common side effect is feeling lightheaded. It is something to be taken seriously, but most of the time it's very mild. It might occur like if you get up and walk around in the middle of the night or if you have to go to the bathroom. We recommend just sitting down. Usually it passes in a few minutes. Stay well hydrated. Prazosin can reduce both the frequency and severity of nightmares. So that's important to note that, excuse me, you could have a situation where you have the same frequency of nightmares, but they're much less severe, and you might even sleep through them to where they don't interrupt your sleep, and you can still get a full night's sleep. So you can get benefit in a couple of different ways. Prazosin isn't the only medication we use for nightmares. There are a handful of other ones. Gabapentin, topiramate, clonidine. Your doctor will know all those that they can discuss with you. But there are other options. Usually, the other thing I'll say here is with medications for nightmares, you want to take them probably 30 minutes before bedtime, maybe an hour before bedtime, but pretty much be all ready for bed by the time you take them. And they usually kick in pretty quickly after you fall asleep. And then most of the time, like in the instance of prazosin, it has a short half-life. And what half-life means is how long the medication is active in your body. And so it's usually not as active by the time you wake up or mid-morning. Okay, another question I get asked a lot is about these list of other treatment options. Specifically, marijuana is a big one, CBD, ketamine, hallucinogens, TMS is another one, ecstasy, MDMA. So these are all treatments that are under trial. There's studies that are going on regarding these these options. Some have shown potential, but I want to emphasize that the National Center for PTSD has not endorsed any of these other options currently until more evidence, until more research is done. And so, you know, we have veterans that say they may have tried one or two of these treatments and it helps. We can't really endorse that at this point. It's just for your awareness, and there are places in the community that will offer these treatment options, just to be aware of. All right, and then so if you want more information, the PTSD National Center website, ptsd.va.gov, and there's a PTSD decision aid, treatment decision aid that you can click on for more information there. Lastly, there's some resources. The National Center for PTSD, PTSD Coach, which is an excellent mobile app. And then, of course, the Veterans Crisis Line, which, as I understood, there's already been a presentation on suicide. So that I'm sure that number has already been mentioned. And it's simple now, it's 988. So anyway, it's just a brief overview of medications. The important points I wanted to highlight are to give the medication adequate time, to know that most side effects are short-lived. They usually do go away after maybe a matter of 1 to 3 weeks, and to not give up. If the first medication doesn't work, there are other viable options, but to remember that therapy is indeed our best treatment option. So that's it. Thank you very much for your time.
Thank you. Thank you both, Dr. McCormick and Dr. Ennis. Thank you for this. I have to say, I just finished watching Masters of the Air. And Dr. Ennis, when you were talking about the symptoms and the conditions for PTSD, I was thinking, oh my God, how many of those kids, you know, it was PTSD, and we didn't have the therapy or the medication back in, you know, World War II to offer them. But I was relating it to what I saw. I don't know if you've seen the program, but listen, I want to thank you both. This was very, very insightful. As a clinician, I learned so much just by watching your presentation, and I can't thank you enough. Please feel free to look at these and all of the videos that we've posted now on trauma-informed care. Thank you both. Thank you for watching.
Thank you.
And thank you for your service.
You bet.